you have to switch these on, or how do they work? Huh?
Good morning. Is it working? Yes. Good morning, everybody. We still wait for some panelists, so therefore relax for another 5 minutes, I think. We'll start a bit later.
Yeah. I can you right now? Yeah, of course. No problem. With the subtitles. Any requests?
I have a good voice, but
You're good. Whatever.
morning maybe.
I just enjoy it.
After the party.
That's good because you were just. Good milk. Oh. You're Canadian, strength. What, you don't have tea with milk? No. I barely have tea. Tea is delicious.
Yes. Benvingut, for men, benvinguda. Yes.
Yeah.
Everyone has a mark.
I forgot my adapter, so mine might die. We'll see.
In Catalan, it's like tots, all, totes, feminine, and then sem totis. Instead of word in Catalan, it's
In Dutch, it's also not too complicated, but in German, it's very, very complicated. It's a linguistic development. It's quite interesting.
and really few people is using it because it's like
In English, it's easier.
Yeah.
It's just What kennst du hier? You know this one? Do you have slides? Yes. Do you want to do it yourself? Or do you want to do it myself? Eberhard will support us. You're also presenting, huh? Yeah, my name is Georg. Hi.
Yeah, this is still, I guess, because it's gasoline. Nie. No. It's a good.
Very good deduction.
Maybe it's not.
Yeah?
No, yeah.
Yeah?
That's the reason we are waiting.
I feel so vindicated that I'm not the latest one, you know? Great. I'm already doing good.
So, Dzień dobry. Good morning, everybody. We decided now to start the session. Maybe the two panelists will arrive in between. So my name is Ruth Zimmermann. I'm working at the National Public Health Institute in Germany as an infectious disease epidemiologist. And the focus of my work is viral hepatitis, focus on hepatitis C, and focus on studies among key populations, mainly people who use drugs, people who inject drugs, homeless people, migrant populations, and incarcerated people. So I welcome you all to this session on scaling up HIV and hepatitis among people who use drugs. Ah, great. So as you all know, people who use drugs and other marginalized populations are disproportionately affected by HIV and viral hepatitis, and this is also because there is stigma, discrimination that challenges or that makes barriers to accessing health care. And therefore the BOOST project was started also, that will be presented later. But first, for this session, we start with two country presentations from Bratislava, Slovakia, and Lisbon in Portugal. And then we will go to the panel discussion with all the participants and present different aspects of the BOOST project to you and discuss them. And I really invite you also to ask questions and to join the discussion. So let's get started. I'm happy to present Dominika Jasekova from Slovakia. She's a psychologist and the director of the Civil Society Association Odysseus since 2018. And she will give a presentation on an analysis of provision of HCV treatment to people who use drugs in Bratislava and gives recommendations for future practice. Thank you very much.
Thank you. Hello everyone, my name is Dominika, and I will be presenting analysis of the provision of hepatitis C treatment to people who use drugs in Bratislava, Slovakia. Why I'm presenting this here now, it's because in Slovakia, okay, first who we are. If you don't know us, we are Odysseus, we are an NGO operating in the field of harm reduction since 1997. We provide many services from needle exchange to drop-in center to program for sex workers and also housing first program and linkage to care and testing and other services. So in Slovakia, the hepatitis C treatment was not possible for many populations until 2023. Because there were various barriers. First barrier was that in Slovakia the healthcare system is not free. Every person who is like Slovak citizens needs to have a health insurance, and this health insurance is covered by the employer. If you are not working, you need to pay the health insurance by yourself, or you need to be registered in special office. So for many vulnerable communities, who are working illegally, or they are not able to register in unemployment office, then they are accumulating debts on health insurance. These debts can be up to 7,000–10,000 euros, and because of these debts, they don't have access to any health care, just in life-saving circumstances. And the infections were not considered life-saving circumstances, so not even HIV treatment, hep C treatment, syphilis treatment. This changed. It was there was a change in law regarding health insurance, so life-threatening circumstances were also broadened to also treatment prevention of infections. But there was still one condition left for people who use drugs, and it was 1 year of abstinence requirement. So people who use drugs or they used drugs in the past and they wanted to get treated for hepatitis C, they need to show with the proof of 1 year of abstinence. So it means that if, for example, someone was a drug user 10 years ago and they found out now that they are hep C positive and they need treatment, the health insurance company, they see in the records that they were admitted for the treatment and etc. and they request the proof of abstinence. So this person needs to wait 1 year in order to get the treatment. This requirement was cancelled in June 2023. So since June 2023, everything is great and we can provide the treatment to hepatitis C. Unfortunately, not everything is great, and when we start to link people to care, we face many barriers and risks. Some of them we overcome, but there are new emerging risks and barriers we found out in 2024, so this I will present in this presentation. There is also one specialty that after every confirmatory positive PCR testing, the doctor needs to write an application on behalf of every patient to the health insurance company to approve the treatment. So this is like bureaucracy, administrative process, which needs to be done for every person by the doctor. So it's a lot of bureaucratic burden on the doctors as well. And waiting process, or the health insurance company has up to 30 working days to reply or to say something. This is the average rate of reactive results with our community. So we have 60% reactivity rate this year, for example, 70%. So the reactivity rate is really high among our community. And for example, this year we saw also among some younger people who use drugs who were tested negative in the previous years that they are also reactive as well. So the risk of barriers. So we faced really long waiting period of time. So when someone was when we linked someone to the healthcare provider and they undergo the PCR confirmatory testings, since then until the treatment, it's taking average of 55 days. So it's a lot of time. Meanwhile, in 2023, we had 2 women get pregnant during this time on 1 incarcerations or other barriers, or 1 person lost the phone and lost contact with us because it's really long period of time for someone in vulnerable position. Then also, if our clients are employed, they are often employed illegally and then they don't have the labor rights. So often it's really difficult to manage with their employees to get free morning from job to go to the blood withdrawals. Many of them, they lack IDs, and the ID is requirement in order to go to the doctor. So of course this also is prolonging the time. We faced many visits to the medical facility. The average number of visits was 7 visits for every patient, and the blood sampling was done every visit. So it was really traumatic as well for the people with problematic veins, and also traumatic for the nurses and for everyone involved. These blood samplings were too early, and they are still too early, between 7 and 8 o'clock in the morning. And also stigmatization and inappropriate comments or questions from health personnel. For example, the doctor asked the client when they found out that they are using drugs, so she immediately asked her if she has a kids or in her custody. And they were not even talking about the kids. Or they were asking, for example, if the doctor is asking whether there was a previous incarceration, and if the client is responding yes, the doctor is asking for what crimes they were in prison for. Or we also, there was like really hard traumatizing moment when the nurse was really aggressive toward the clients because it was not possible to withdraw blood. So at the end, the client needed to sit on the floor and take the blood from groin herself, and there were many people around her, walking, random people, and yeah, it was really hard, and then she had problems for many days. Of course, there are other questions like why they are using drugs, what is behind using drugs, they should stop using drugs, and these kind of comments as well. We managed some changes since 2023. So usually in Slovak system, a client needs to have a recommendation from the GP in order to get a specialist care, but many of our, or almost no one has a GP, so it's not possible to get a recommendation letter. But with our cooperation with the specialists, we are able to, we don't need to have a recommendation letter. It's just linkage from our organization is enough. So in order to get a confirmatory PCR testing. Also, we were able with one doctor to manage to decrease the number in the visits to 2 visits at the beginning of the treatment and then at the end of the treatment with the 2 blood samplings. Management of the pills, we were able to also improve somehow because before, like the patient needed to pick up every month new bag of pills. We also present the analysis on the National Hepatological Conference with the hepatologists and infectologists with emphasis on reducing the stigma from health personnel. It was kind of successful in positive and negative way. So yeah, they were talking about this presentation for long, as I heard later on from the doctors. And also we were able to reimburse clients for transient elastography fibroscan because since September 2024, this procedure is paid for everyone for 30 euros. And some doctors are requiring this with every patient regarding to the level of the state of liver. There are some ongoing challenges we are not able to still solve. The absence of ID or mobile phones are really worsening the adherence to the treatment or to the linkage to care. There are personal data are required for making an appointment, so we need to ask the personal data when making an appointment, and we are anonymous service, so it can be some barrier for the clients as well. There is a presence of other health problems, which the doctors or these doctors who are really interested in the health or overall health of the patient, they are suggesting or motivating client, but due to the healthcare system and the debts, it's not possible to link them to other care. And of course, sometimes the clients don't want to go. They just want to treat Hep C. There is persistent stigmatization of people who use drugs. Also, the storage of medicine and its administration in Slovakia is illegal for us to store the medication and the pills. But of course, if there are people who are experiencing homelessness, they are often, they get stolen their personal items. It's difficult for them to keep 90 pills with them all the time. And also the challenge is that the practice varies from doctor to doctor, so we don't have standardized procedure. So it's also based on our cooperation with concrete doctors, and some doctors want this, some doctor wants that. And yeah, this is really a challenge. I bring some case studies that what happened this year. So we already had like 2 reinfections within the linkage to care. They were, since they were in 2023, they undergo the treatment for the first time, and in June this year they were found positive again. They were able to undergo the treatment again, so now they are under the treatment. They are finishing in December, but we were told that this is the last time they are able to get the treatment, that it will be not possible 3rd time. So this is what we need to think about in the future. There is also stolen medicaments. One client, she picked up the pills and they got stolen from her, like full package. She went to the police because the pills cost 8,000 euros in Slovakia, the one box. And the police was really violent towards her. They were shouting at her. They were saying that they don't want to get infected by her, and finally they shunned her and kicked her out of the police station. And when we were talking with the doctor about this situation, the doctor told us that the replacement is not possible. So she couldn't, so she just went through 2 boxes of pills, not the 3, because the doctors couldn't give her more because of the approval process from the Ministry of, from the health insurance company, and this approval is only for limited numbers of boxes and limited number of time as well. So for example, if someone's treatment is approved, but for example, for some circumstances they are hospitalized or they lost contact with us, and we will come into contact with them after 3 months, the doctor needs to write an application again because the approval is only for limited period of time. And also, this is quite recent case that we are facing. One client was employed in Tesco, and then when they went under examination from this labor doctor, they found out reactive test results, and what the doctor done was immediately called the director of the Tesco store and saying that this person is positive and they need to kick her out of the job, they need to fire her without the PCR confirmatory results. So the client went to confirmatory PCR results which were negative, but the doctor of Tesco is still persistent on firing this person, and even the infectologist is saying the client that she is positive, that she can infect everyone even though she has negative PCR results. This infectologist is in the east of Slovakia, so maybe the education is also something that needs to be done for the health care personnel and for the infectologists as well. So even though we made great progress in terms of linkage to care for hepatitis C, we still have a lot of work in front of us because for now the treatment is not available for everyone. Thank you for your attention.
Thank you very much, Dominika. That was very, very interesting and very important work, I think, and really thank you very much for pointing out all these challenges you face. Are there any questions from the audience? Yes.
So congratulations, really, this is a huge achievement at work you are doing. Treating drug users, active drug users even, and if I understand correctly, it's only the specialists who can prescribe DAA treatment. So to avoid this stigma, which I'm very well aware of, have you perhaps already thought about the possibility of decentralization? Because as I understand, some doctors are keen on doing it with empathy and appropriate attitude towards the drug users, so that you would perhaps at your civil society organization or wherever make some appointments with doctors, taking blood, doing treatment and so on, if there is possible, or perhaps in the nearest future, to avoid all these barriers.
Thank you for the question. Yes, the person who can prescribe Hep C treatment is only infectologist and a hepatologist. And we were thinking about bringing the nurse at least, or the doctors to the drop-in, but there are many challenges in terms that for the doctor to be, for them to worth it to go there, they need to have at least X number of clients. But when we are testing some clients and they are reactive, they don't have, like half of them, they don't have an ID. So the process of ID and everything and the waiting period, so it's better for us to do it individually with the persons at the same time when they found out that they are positive. But at that time, we are not able to provide the doctor with 15 clients that they will show up in the drop-in for the confirmatory results for them to be worth it, like financially or otherwise. But we were already speaking about this with the doctors and the nurses. Also the times that some of them, the operating times of the drop-in are not good for the doctors. We are outside of the city center, so this is also some other barriers. So yeah, but we are still thinking about this and yeah, discussing it.
Thank you very much. So I think we continue with the next presentation. I'm happy to introduce Carolina Marquez from Lisbon. She's a psychologist. She holds a master in criminal psychology, and she's working in the field of harm reduction in the Lisbon Arresto Penal. Sorry for the wrong pronunciation, probably. So this is the great NGO we all know, I think, from Lisbon. And Carolina will show us the benefits of a public-private partnership with the university hospital, right? So happy to see your presentation.
Hello, everybody. Well, my name is Carolina. I'm a psychologist working in harm reduction since 2014. I work at the mobile unit, Methadone mobile unit. I'm the coordinator of the team. And I also made the technical supervision of the case managers at the municipality emergency shelter of Santa Bárbara. As Ruth said, I work in Arresto Penal. That is an NGO that started in '86 with a therapeutic community. Since then, we developed a lot of projects, always focus on preventing harm reduction, treatment and rehabilitation, and since COVID, we focus on people who are experiencing homelessness. I won't talk about all the projects because we only have 10 minutes, but we have a DCR, an emergency shelter, transitional flats, rehabilitation flats, therapeutic community, and the mobile outreach program. Our clients, that's a big frame, are mainly men. The average age is 45 years. They have things in common, like poor experience in working experience, low education, fragile condition, psychopathology, prison history, and they are aged. We have mainly people from Portugal, but also from Asia, Europe, Africa, and America, in this order. I won't talk about all of the projects, but I will talk about 3 in a rush. Because these 3 are the ones that we implement our decentralized consultation. The first one is a mobile outreach program. That is a program where we have 1,400 people per day coming to our mobile unit. They have high-risk behaviors, personal disorganization, physical impairment or diseases, and so on. And on that program, we have case managers that seek the personal needs of person, not only clinical, but also social, and they refer people to the community services. Then we have Santa Bárbara Emergency Shelter that also works with case managers that try to promote some dignity for people who are staying at the street. We have space for 128 clients. They can do their medicine over there. They also have a drug and alcohol consumption room, and I think that's a very important thing because we had people at the streets, and then we put them at the shelter, and they needed to use. And if they were using by night, they will miss the night, and after 3 nights, they miss the spot. So we needed to have spaces, free spaces and safer spaces for them to use and not lose their beds. We also have a psychosocial team, GP weekly, psychiatrist weekly, a nurse and educators. Our fixed DCR, as Hugo presented yesterday, we have 3 supervised consumption rooms. We started with 2, and now we have 1 more smoked. It's not only the DCR, we have other things at the DCR like coffee desk, psychosocial appointments. We have a place where they can have pets, laundry and shower, and you can see a regular day that has 300 entries, only with 170 new persons, 214 usings, 90 snacks, 12 showers, 5 social appointments, 4 GP consultations, and 80 acting nurse acting, sorry. Forget about the title, it's wrong. I just want to show you that this data is from the national report of 2024 for the viral hepatitis. And we can say that Portugal compares very favorably with the European average, with 1.6 confirmed cases of hepatitis C per 100,000 inhabitants. In Europe, you can see 6.2. So, now I will talk about how this decentralized consultation has started. So, we started with a study in 2015. We were called to action for an hepatologist working at a central hospital in Lisbon. At that time, we need to screen our population and see what do we have in numbers and what do we need to do before. I won't talk a lot about this study. You have the QR code if you want to see more, and if you want the article, I can send you. Just tell me after. So, on that study, they start doing a brief questionnaire, and then we collect the antibody to see if they are positive, and then with a C5 machine, we do the RNA. If they were positive, the doctor will refer them to, or will give them a letter to go to the health center for them to be referred to the hospital. So, it's from this that we went to our new model that was evolving during the times. So it starts with this referral to the primary care in the health centers, and the adherence was 10%. Even though we have 300 persons referred, only 30 were consulted, and only 10% adhered. Then we thought, that's not enough. We need another thing. So we talked with an hospital, and we start to taking them with a peer navigator, and that went better, 45%, even though it's not enough. We needed more because they needed to go a lot of times, and during the process, we'll always lose someone. So we evolved to the other model from 2019 to 2020, where we had an hepatologist at the van, the mobile unit, that made the appointment, and then all the process is gone after that. But in 2020, we had COVID. So it was very, very difficult to have people at the mobile unit doing appointments. So we start another model, and we start doing everything on our mobile unit, since the screening, and then with the C5 machine, we understood if they need treatment, and if they do, the treatment would come to the van, and they will do it all in the van. Even after the treatment, they can do the blood analysis to confirm, always in the van. At that time, we have another mobile unit for them to do the consultation by a screen. So nowadays, how it works? In the mobile outreach program, we screen all clients. In our drug consumption room, we try to educate them to screen, but it's not mandatory. So we are always talking about screening, and if they want, we do it. At the emergency shelter, we screen all the residents. So what we do, blood sample or a rapid test if it's a migrant. In our National Health Service, it's difficult for migrants, so we need to do it in other ways. So For that, we do all in our facilities, and they can start the medication for Hep C and for HIV too, and also syphilis in our facilities. They can do it all in our facilities. This is our numbers for now. We have screened 825 with antibody 483, positive RNA 129, treatment ongoing 7, treatment waiting 7, and treatment completed 65, sorry. This is our population, mostly men, average age 41, Portuguese, Asian migrants, Eastern Europe and other countries. And for you to think about it, resilience is essential for professionals. Shifting the target population because we have more migrants every day. Teams need to evolve to keep up with their clients' needs. It's not the same that they were 10 years ago, so it's very important for us to keep evolving. People who use drugs want to get their hepatitis C treated, but it's not their priority, it's ours. It's only possible to achieve screening and treatment by creating a trustful relation, and decentralized consultation is the key to improve treatment adherence. My mantra is, left no one behind, unless they want it. If they want, we will respect their will. That's it. Thank you.
Thank you very much. That was really great. I liked a lot how you improved stepwise your program, and when you realize that there is a problem, that something needs improvement, you each time improved it. So very great. Thank you so much. Any questions from the audience? Yes.
I wanted to ask that if it's mandatory for the clients to undergo the testing when you are screening all the patients, or there is like this consent so the person can refuse in the mobile outreach on the emergency the shelter to get tested if they don't want to?
It's not mandatory, so if they want to do it, they can do it. Even though if they don't want to do it, we will try to talk with them. That it's very important, but in the final line, if they don't want it, they don't need to do it.
Okay, any other questions? Yes?
Yeah, so they do it. Not at the mobile, but in our fixed facility at the DCR. So we collect the blood in the mobile unit, for instance, and then we let them at our DCR, and with the C5 machine, we do it.
Okay.
You asked about, sorry, FibroScan, sorry. Sorry, no, it's possible. If they need to do it, we can let them take them to the hospital and do it, because we have a strong connection with the hospital, so they can do it. But you don't carry it inside? No.
Okay, thank you very much.
Thank you.
So we now start with the panel, and we have different persons representing different parts of the BOOST project. And I want to start with Georg. Georg has a background in social work and cultural anthropology, and has been working in HIV/AIDS for many years. And he will present some give some general information on the BOOST project.
Yes, thank you very much, Ruth, and also thank you very much to the conference organizers to give BOOST quite a prominent place in the conference. We had a workshop, we had discussions in the networking zone, and we had also different presentations. So my name is Georg Bröhring, and together with Katrin Schiffer, I coordinate the BOOST project. And in a nutshell, I just want to summarize background, main activities, and also the partners, because we have many people who do the real work on the panel, so I just keep it brief. Next, please. So I think the first ones are quite clear. It is still on the agenda, a serious public health issue, and that a lot of initiatives do exist in Europe, but that we wanted to go more in depth, indeed, to boost all the activities in the field of HIV and hepatitis. And also that the Boost project very much linked to the European health program, so it made sense to start with this initiative. Another factor was also that the correlation network was very helpful in combining the Boost objectives, the Boost activities, with a wider network of correlation. So it's really a synergy that we could create with this project. So that led at the end to the agreement between the European Union and the Regenboog Foundation correlation to have a contract to implement Boost from 2023 to 2025. So we will enter the last year shortly. 2 years have been done, and now the last year is also very much on implementation. Well, the main aim is to enhance the implementation of high-quality, community-based communicable diseases services as part of a comprehensive, people-centered and integrated harm reduction approach. That's a whole mouthful, but the focus is really on community-based and also on integrated harm reduction approaches. So we work in 4 main areas. Iga, welcome. The first one is inform, and inform means to collect information but also disseminate information. The second one is improve. That includes a lot of training activities. We will come to that later. Support is an important area of work that is really to support emerging organizations. We have selected a few lighthouses who in turn then support smaller NGOs in the field of harm reduction. And the fourth one is Connect and Act. That is very much about advocacy, to put organizations together to join forces and put also the results of the project on a political level. So these are interrelated work packages. Come to the next slide. And interrelated is a chance, but also, of course, a challenge, because one work package needs to wait for the other to get the information to go on going. But after 2 years of experience, I think we are pretty well on track. For those of you who know European funding, they work with work packages. First one is coordination, that is done by correlation, Regenboog. Inform work package, we hear more from Laura and from Iga. Improve about the trainings, we will hear something. Then work package 4, next please. We had a workshop yesterday on this area, so that's why they are not on the panel today. And the same for work package 5, the advocacy. We had an activity in the networking zone yesterday in which we also got feedback on our advocacy strategy and to discuss the way forward. Work package 6 is super important because they monitor and they also take part in the communication of information. And we work very closely, the colleagues are here from IS Global. We work very closely also with the first work package for the coordination, because monitoring and the coordination are very closely linked. So that's in a nutshell the overview of the activities and how it is organized. And we don't do it alone, of course. We work with a number of harm reduction activities, organizations, and also some bigger networks, like the Eurasian Harm Reduction Network, Euro Input, here also on the table, which other, and DPNC, of course, for Southern Eastern Europe. So that's in a nutshell the framework. And once again, I will not talk so much about the contents, because that is my colleagues who are more experienced. Thank you.
Thank you, Georg. So, thank you very much, Georg. I think we continue.
Yes.
And come to Laura. Laura Fernandez-Lopez works as an epidemiologist at the Center for Epidemiological Studies on HIV, AIDS and STI of Catalonia. And Laura, you will present on the COBA test project, sub-project of the BOOST project, and you also have some slides, I think.
Yes, I have some slides. It's a short presentation.
Yes, and maybe you can already focus on challenges you face within this sub-project of the BOOST.
Yeah, the idea is, as Ruth said, work in CISCAT is the Center of Epidemiological Studies of HIV and STIs, and we, together with AIDS Action Europe, we are coordinating the COBA-TEST network. That is a community-based testing, is network that links, connects community-based testing services across Europe and Central Asia. And in the BOOST project, the main idea was to try to adapt the tools that we have at the COBA-TEST network in order to be useful for harm reduction services that are already testing for HIV and hepatitis and STIs at their services. Just to, you can, I have this, can I have this? So it's going to be easier. Thanks. Oh, sorry. So mainly, why the need to adapt the tools. The idea is that we know that there aren't enough harm reduction measures for HIV and viral hepatitis among people who use drugs. And so it's important and urgent to expand prevention and testing services especially through community-based harm reduction organizations. We know that organizations are working and are doing testing, but there's not enough public data on how they are doing this work, so we think that it's important to have this kind of data. So the COBA-TEST network, as I said, is this network that connects these organizations that are community-based organizations that are doing testing. Currently, we have around 137, in fact, 58, because last week, a new organization from Poland joined the network, from 29 European and 2 Central Asian countries. And in the map, you can see all the countries where there is at least one organization that is a member of the network. Those are the partners share with the network harmonized, standardized data on the activity, on testing activity that they are doing. Yeah, so we have, I mean, the members can share the data in different ways, but we offer them an online tool, a free online tool that they can use to share their data with the network, and is a way to collect easily all the data for all the persons that they are testing at their services. So this online data collection tool is very easy to use, and it's basically you can collect a standardized data. There is the option to select different models according to the needs of your key populations, and you can also ask for specific models for your service. You can manage your data easily. You can also adapt it to your own language. If you required that, we can have this translation. And you can easily extract and analyze the data that you have entered. So you can produce reports, you can produce graphs, etc. And of course, if you share the data if you use the online tool, or you share the data in a different way, your data is going to be part of this joint report that we try to do once per year. Okay, how we do this process of adaptation. Basically, we established an expert group among the BOOST consortium members and also among the BOOST advisory board. We had 2 online meetings with this expert group. We share prior to the meetings, we share a background document outlining everything about COBA-TEST, what is COBA-TEST, which is the indicators that we are collecting, the data collection form, etc. And then with the proposals and all the feedback that we received from the expert group and the discussion that we had during the online meetings, we decide the new questions and indicators to include. We follow a consent decision-making process to reach the decisions. This consent decision-making process is more focused on getting no one disagreeing instead of everyone agreeing. So it's a much easier process when you have a lot of things to decide and a lot of people. And at the same time, we do a parallel process in a core project that is another action grant. And we do like the same of work. And it was really challenging at the beginning because we had 2 different expert groups with different expertises in different areas. And, but at the end, it was a really nice process because I think that all the expert groups accepted the expertise of the other group, so there was no collision on that, so it was a really nice work. And yeah, at the end, when we have all the changes done, all the changes have to be approved by the steering committee of COBATES. Of course, it was another process, but again, all the decisions that were made by the expert groups were accepted by the steering committee members, and then we also presented all the changes to the members meeting of COBATES, because all those changes apply to all the members of the COBATES, not only for the new members that are going to join for harm reduction services, but all the services. Because at the beginning, one of the ideas that we had was to try to do a specific model for harm reduction services. But during the discussion process with the expert group, it was decided not to do that, but try to include the minimum need questions and the general model. So in this way, everyone can answer those questions, not only harm reduction services. So we are going to get more information from all the people tested, not only, if we have done the model, only those harm reduction services are going to use that questions. No? So at the end, it was, we added few questions because it was, at the beginning, everyone wanted to add a lot of questions because everyone wants to know everything, and it was a kind of, oh, we can ask that and we can add that question. But it was a kind of self-regulated process because at the end it was, okay, we need to be as short as possible because we need to ask all those questions every time each person is going to be tested in our services, so it's going to be long if we add a lot of questions. So it was a kind of this self-regulation process that at the end we keep the minimum necessary questions. And I think, okay, those are the questions that at the end, not the questions, but the issues that at the end we decided to include in that process. The main routes and frequencies of drug use, which are the main drugs used, sharing material for injection and non-injection drug use. Well, first of all, the concept of drug use, because at the beginning, we just asked it about injection. So we changed that concept. We add the concept of drug use, and then ask about which route, and of course, we include injection. If there was injection in prison, if they were under opioid agonist treatment, if they experienced homelessness, and we also add everything related with HBV testing that we haven't before. So now we have HIV, hepatitis C, hepatitis B, and syphilis testing. And yeah, the idea of what we expect with all those changes, at the beginning, we can help harm reduction services to collect and share standardized data. With this, we can improve data on drug use and related issues. And I think that we can increase awareness on these important groups' needs, supporting better services and choices, IM policies, sorry, and all this will help advocate for adding this data to national systems and show how community testing fills gaps in care, improving HIV and hepatitis diagnosis and treatment. And I think that's it, yes.
Thank you very much. Thank you, Laura, for presenting this important tool. I quickly have a question. What about data protection? It seems really like a great tool also that services can produce their reports with it and so on. So it seems really great, but I wonder what about data protection? Any issues?
Yeah, the idea is try to use anonymized data. But it's always difficult because what is exactly anonymized, it's really a discussion that we have internally always in our group. But because we need to collect, we try to collect an identifier, a unique identifier, to be able to count not only tests performed, but people tested, so we can count repeaters. We suggest a code that we use in COBA-test, that it's anonymous, because it's like, if I can remember correctly, it's like the date of birth, the gender, date of birth, and then questions like how many older brothers do you have, how many older sisters do you have, and the initial of the name of the mother. Wow. So it's a kind of code that you can always answer the same. Yeah. Not always, I mean, there are a lot of problems always, but it's a kind of, so it's anonymous at the end, and you can always get the same, more or less, answer, so you can identify repeaters. And what we ask to the centers that are members is that they respect, in their policies, in their services, that they respect the GDPR. So this is a kind of how we solved.
Okay, thank you very much. Are there any questions from the audience? Otherwise, yes?
So could you ask, because centers can take out their own, export their own data, so each center has their own data, they don't export data of someone else. So,
yeah, each center has only access to their own data in the database. It's not, you cannot access to the rest of the...
Yes, of course, thank you. Okay, so I think we continue with Iga. Welcome, Iga.
Thank you.
Iga is, or you can just present on the multi-modular survey, and maybe also already focus on some challenges you face with the data collection after the first round.
Yes, thank you very much, Ruth. I will be very, very brief regarding, I think that we had many sessions on monitoring and gaps in service provision during this conference. And some of you I see already that were at our monitoring session yesterday morning. So we conducted a multi-modular survey last year during the summer and autumn, and kind of in contrary to the monitoring that we do normally with correlation, we asked organizations to provide information about their own services, not services at their city level. So they weren't kind of asked to extrapolate their information to the entire city, but pretty much the goal was the same. So we wanted to identify and map gaps in service provision, and not surprisingly, what turned out is that stigma is one of the main barriers to service provision in the context of hepatitis C and HIV, especially that we also ask how services are being provided to people who use drugs, and infectious diseases services are mainly provided, it seems, through referrals. And one of the main barriers that was identified to affect cooperation with other institutions like public health organizations and so on was exactly the stigma and people's reluctance also to identify as a person who uses drugs, but also stigma around harm reduction, low threshold service organizations themselves, kind of by extrapolation again, that results in a situation where different organizations, different institutions are reluctant to cooperate with them to provide continuity of care and a person-centered care programs and case management. So the challenges in the data collection, so that's a challenge regarding the service provision. I would say that stigma is just the evergreen topic that and we can talk about lack of capacity, lack of funding, and so on, but like in my personal opinion, this all stems from stigma ultimately, right? So this stigma, I think, is this underlying issue that affects the political will, that affects the funding, and so on and so on. Now, the challenges in the data collection, I think that the main one was that we distributed the questionnaire among members of four networks: Correlation, European Harm Reduction Association, Drug Policy Network Southeast Europe and EHRC. And we had a lot of feedback that it would have been nice to have the survey translated to Russian for the more Eastern participants for whom this is their first language that they speak. And we struggled a lot with getting the number of responses that we very ambitiously assumed that we can get. The numbers were really, really very, very bad. At the beginning, we assumed that we can have around 100 responses, which would mean that we would have like 60% response rate. So that's very, very optimistic, because the survey was sent to more or less 250 organizations, and we ended up with 65, I think, with maximum 65 responses. So the coverage basically was the main issue, I think, and the main challenge. We are going to repeat the survey this year or beginning of the next year. So hopefully we can learn from our shortcomings in the previous edition and make this time kind of achieve higher response rate and therefore more kind of complex picture of what's going on in the field in Europe. Thank you.
Thanks, Iga. Thank you very much. I think some applause. Yeah, I think, I mean, this is also what we face. The harm reduction services already have a lot of tasks and a lot of also they are also ambitious to do a lot of great things. And then when it comes to data collection on top of all these tasks, this is really challenging, I think, and this is what we see as well. And yeah, but nevertheless, the data is so important, so I keep fingers crossed for the next round. Are there any questions to Iga regarding data collection in the multimodular survey? Yes, Georg?
No, maybe just one thing to add, that is also part of the entire BOOST project planning and implementation, that in the beginning sometimes you're just too ambitious. I think also for the survey, the idea was have it every year to see tendencies. But it would have been so labor intensive for those who respond and also for us to evaluate that we said it's not realistic. So then we also have to adjust a few times what was the original planning. So just in addition, but for the rest, I think it was very...
Yes, the survey had, I think it was around 60 questions, so that was quite a lot. This time, I'm just now trying to kind of reach out to all the service providers who will be sending surveys at the beginning of the year. It will not be that long, okay? The first round, we also included needs assessment questions to inform the work of the other working groups. So we had questions about the assessment of digital skills in the organization, for example, and so on and so on. And now we only focus on the situation with service provision in the organization. So I think it will be probably like 20 questions maximum. So yeah, please do not be scared.
Okay, thank you. So we come now to digital health. I'm happy to introduce Mireia Ventura. She holds a PhD in pharmacy, and I think you are the queen of drug checking services, right? But you are also the project lead of the, how is it called, digital skills, so, or digital health work package of the BOOST project. So,
it's called Improve.
Yeah, maybe you can present this sub-project of the BOOST project and also point out what role plays digital skills in this package of infectious disease testing and treatment in harm reduction services. Thank you.
Thank you. So the idea was to try to find ways to improve the digital skills from organizations, and first also what we want to do is to collect all the resources that already are. So with the help of several partners, with Lila, and also with Regeneration, we were able to try to dive, no, and try to find every digital resource and every app that could help people to implement services online, but also to follow up, to understand, to integrate a little bit more the digital tools that we have. And then this was the first part of a big training that we developed. The training was done this last March, and then later we had 4 different sessions. One, it was talking about the role and specifics of digital services, and then it were present all the services that are existing. Also in another session, we were also talking about the digital service planning and management, but also another one specific about how to build practical digital skills for quality service and also how to implement these online services. And a last one about ethics, safety, confidentiality, data collection and processing, and also all the relationship with clients in online environments. And then this training, what we learned from this training is that most of organizations that attend, they felt that they don't have a lot of digital skills. So when we asked them how you feel before, most of people declared that they felt that mainly they didn't have these digital skills. And then after the training, also we were happy because more than half of attendants were going to the 4 sessions. Finally, we had at the end 73 different participants, and 34 were attending all the 4 sessions. And then after these sessions, when we asked how they felt about the digital skills, all of them, they were rating much higher. So we contribute something, but one of the phases that we are changing, that we are facing, is that there is not a lot of good distribution between countries and between services. So we found very different levels, so from persons that are already used to use database, electronic database, I mean, but also persons that are very involved in this digital environment, but also other organizations or countries are not in this level. So then it was very difficult because the level is very different, so it was challenging to try to find a way that could be also helpful for everybody, because when you have such different levels. And then also another big challenge was the language. So we need to adapt, and we decided to translate the presentations to Russian, and also to have a person who was attending at the trainings at the same time also translating, because if not, again, the capacity that we have to reach these other countries or services was impossible. So also this, we could fix it at the same time, including this specific translation from Input. They were providing a person who would translate even the presentations, send it beforehand, and also online. And this was a little bit the way that we tried to reach all these different associations.
Thank you very much. Any questions from the audience to this project, Digital Skills? No. So I think we continue. We come back to you later with the last introduction of Lynn. Lynn is presenting the ENPUT, European Network of People Who Use Drugs, sorry. And I think you are representing really a very important part also of the Boost project. This is community involvement, and I think this is the crucial thing that we all need. So yeah, please present your part of the Boost project, and also what barriers, challenges you face in your work. Thank you.
Thanks very much. Sorry.
All voices are affected by the mic.
That's true. That's true. So, yeah, so EuroInput's involvement in the Boost project, we're part of mainly every work package having bits and pieces to do with work package 2 to work package 5. For those who don't know us, Euro Input is the regional drug user network supporting and fighting for the health and human rights of people who use drugs in Europe and the neighboring countries. So yeah, our involvement in the project was to ensure community involvement in kind of all aspects of the different work packages. So I'll just briefly go through what that entailed in each work package. So for work package 2, we had a values and preferences study. So this was focus groups discussions that was developed and informed by an Australian peer activist and researcher, Dr. Annie Madden. So these focus groups took part in 4 different countries, 4 different cities, and it was led by a country focal point and a note taker. And an important note on language is that the discussions were held in the local language, which was very important. And it was supported by technical coaches from Euro Input. So important to mention that the Boost project and Euro Input is not just me. We have a team of 4 project managers, myself, John Melhus, Joanna Canedo, and Ligia Parati. So it's a team effort, and I'm very grateful to have that team working, you know, in terms of delegation and workload. So yeah, the focus group discussions, I will go briefly over the findings. So we had Antwerp in Belgium, the needs and barriers in terms of access to HCV testing and HIV prevention, harm reduction, was that they discussed the need for drug consumption rooms, prescription heroin, so heroin-assisted treatment, drug checking services, and naloxone distribution. Actually, the findings were quite varied in each different focal point city. So then we had Brno in Czechia. Bruno highlighted positive social support, especially peer support, was crucial for accessing and completing Hep C treatment. So that's one thing that came out of the focus group there. Finland, Helsinki, they had concerns about the legal consequences and stigma, particularly for women and young people. So again, like a really varied range of feedback from these focus groups, even though the questions and the discussion was a template of the same. So, and then we had Rome, Italy, where people who use drugs were facing barriers in terms of geographical distribution, cost and refusal by pharmacies, and then also challenges just overall in accessing HIV prevention services. Overall, the values and preferences study did highlight the gap in how services thought that they were performing and how peers were experiencing the service. So that is something that came up that we wanted to kind of explore more, which I'll go over a little bit later. The other thing that we did in the project was, for Work Package 4, was a collection of best practice, which my colleague helpfully gave me at the beginning of the presentation because I forgot it. So you can come have a look at this afterwards. It's basically a best practices on community-led approaches to HCV testing, treatment, and care. Technical briefing that looked at 2 best practices in GAT in Moraria in Lisbon and Norway's Prolar hepatitis bus. So these are 2 very different examples of peer-led services for HCV testing, treatment, and care. GAT is a static site that has peer workers, drug consumption room, doctors, nurses, and provides connections to hospitals or medical services. And then Norway's hepatitis bus is a mobile bus that services rural areas, so again, providing those linkages, and is also staffed with peers. Just an important conclusion from that was that peer-led services and the privileged access that peer-to-peer linkages to testing, treatment, and care provide a safer space for people who have maybe experienced stigmatizing language from medical staff, like you brought up in your presentation, so kind of trying to repair these barriers that people have faced. We are also part of the advocacy work package, where there's advocacy grants, and 3 of the 6 grants were given to peer drug user groups, which I think is a really cool distribution of community-led services and community-based services. We are also developing a policy brief, so this work package is led by Ligia Prati, who presented yesterday. We also have the digital tools that Maria is leading with mentees. We have peer-ups in Greece, Ariel in Slovenia, street support in Brno, and Jadud in Catalonia. So these mentees have attended the digital tools workshops and also taken part in peer-to-peer webinars. We have the mentoring using our technical briefings, such as this one. So really involved in kind of every aspect, and it's really cool to see. So in terms of next steps, we have Joanna Canedo leading a peer-led consultation adaptation, so it's actually adapting from a correlation monitoring survey, which is around 300 questions, and it was adapted down to 30 in order to roll out in a peer-to-peer way. So that's just being collected now, that data. So a lot of different pieces in this project. Really cool to see. There's the community-led monitoring piece, I think, that we're doing now, that we're developing, is an interesting next step and a development from what's come out of this project. And also, in terms of work package 4, we have the mentoring of lighthouses for best practice for peer involvement. So again, just like growing in terms of the mentorship and building our capacity as a network, but also like sharing it with our colleagues, which I think is a really cool piece of the project, and I'm happy to be part of it. So I think that's it. Thanks.
Thank you very much. Yeah, that was great. Thank you for you already brought everything together, so, and you are involved in in all of the modules, so this is great. Thank you so much. Are there any questions to Lynn? No questions? Okay. Yeah, go
Sorry about that, but no, I would like just to add a little thing about, especially of the focus group discussions. It's not only about the results, but also the methodology has been described. So in the reporting, you find also how do you address it. If you look at the overall results, sometimes it's not the big numbers of people who participate, because it's much more also in-depth information that you receive from people and their own experiences. So please also have a look at the Boost website, where you can find all these documents, and especially for the focus group discussions, I found it very interesting to look into the methodology. How do you address people? How do you invite them? What is needed to have also successful interventions like that? Just in addition to that.
Yeah, so if you are talking about numbers regarding focus groups, I just wanted to mention, I think like Joanna is not here to correct me if I'm wrong, but if I'm not wrong, then she said yesterday that for the survey that you launched, you have like 150 responses or something like that, which is a huge number, extremely unexpected, very, very good, really, response rates, very impressive. Yeah, kudos for that.
Yeah, just to say, Joanna's doing amazing work. So that survey, or that adaptation was the same questions that Correlation uses, just adapted to be accessible for peers to then, peer workers to then interview their peers. And there was 30 questions, 4 focal points doing the interviews, and we got 121 responses. Yeah. So yeah.
Exactly. So one more thing. So one of the lessons that we have, not from Boost necessarily, but from our monitoring, and we've been working on reformulating, kind of transforming our data collection survey questionnaire this year, and the questions are formulated basically in a very, very extremely similar way in the MMS. Is that you not only should we not only should kind of make questions understandable, as simple enough for the community, but also it seems for service providers, because like for me it was almost a revelation that, you know, people just don't understand what we're asking. You know, what is availability? What is accessibility? We just ditched all of these abstract words from our monitoring surveys here, and I think that's a lesson also that applies to the data collection at Boost, that we who analyze the data, who develop the data collection instruments, we just sometimes really don't take into consideration enough that people who provide services, they speak just different language. And this is one of the big lessons that can be applied also in this project and in any other project that we collect data in.
Yeah, thank you. Yeah.
And just one more comment, because the survey also looked at the monitoring that has been published before, you know, the reports, and what services were saying about what was being provided in their country. And then peers were looking at that and going, oh, well, this says we have naloxone, but actually it's really hard to get naloxone, you know? So it was giving that kind of perspective on what the services are providing, but actually what the peers are accessing, you know? So it's really cool.
Yeah, very important points also. Really, I mean, questionnaires should be pre-tested, I think, and also when you translate them, they also need to be back-translated and so on, so that they are understandable. Very important. Otherwise, we don't need to do the data collection. But I mean, it's a process. Also, we are learning all the time. So we have 10 minutes left. I would like to invite the panelists to one final round of comments. And here, maybe we should focus on success stories. What went well from your perspective? And I want to start with Dominika. I'm especially interested in how you tackled the stigma. You mentioned that you were in this hepatologist conference or something like this, and how did you tackle stigma among the professional healthcare workers?
So at this conference I had a presentation with the analysis of how many tests, like with the journey of every client, like what they needed to be done to finally get to the treatment or the different circumstances. So it was like a graph, like these people tested, reactive, negative, ID, yes, no, prison, pregnancy and everything. So they just look at the journey so they could understand that when they are finally there, it's a great success, and they should be they shouldn't be punished or stigmatized for any other things, because it showed great strength and motivation to actually arrive there. So in this presentation I wanted to show that, to make it realistic for doctors, because they don't see anything what is behind of the work we are doing, and what is most important behind of the work the people are doing, what they need to overcome to get there. And also, like, if there is lack of phone or the lack of data, or if they are coming from tent to the appointment. So the doctors were completely shocked. And I think it also I just call out. I was not naming any doctor, but I said what was happening behind the doors. And thankfully we know this because we are there with the clients, with every appointment, if the client wishes. So we have also strategies, or we are discussing prior with the people, like if they want us to be there, and when we are there, how we should interact there, what they want from us, if they want that we are speaking if something is happening, or we are not saying nothing and then we can speak afterwards. So this is also important, to have these clear rules with the people, what is our role there when we are there behind the doors with the doctors. And thanks to that we were there, we could point out these comments and point out why they are stigmatizing and why this shouldn't happen. So, and since then it improved, but of course when the relationship is building, now we face that we have really good cooperation with one doctor and the nurses. But then she's now starting to be curious. She's starting to ask what the crimes they are in prison for. But it's not why she needs to know that. And also now the nurses are getting more comfortable with us or with the clients, so they also are starting asking questions which are not related to the hepatitis C treatment. So now we need to navigate different type of barriers to the relationships.
Thank you. So the dialogue is very important, and also yeah, concrete examples of what happened. I think this is a good message. So, Carolina, you already showed your great example, but maybe you can point out again what was really, how did you build this relationship with the hospital, and how did you make them come to your services, and what would be important messages to all of us?
Okay. It was our needs, but it's also their need. So at the time of the study, it was starting the DAAs, and this doctor that is from an hospital in central Lisbon were seeing a lot of people from our program. So we needed to understand and learn more about it. So he talked with us to start this. And before this hospital, we'd start with another, and then another. Because we always had a straight connection with the hospitals, because we always need them when we have a client that needs to go to an appointment, or even if it's being hospitalized. So it's quite natural to build this relation, and after that formalize it. So it was easy, I think I can say that. Of course, it had some difficulties, but I think we all need each other, so it was very important. They need us to have the clients, and we need them because we need to give more conditions for people. So it's a win-win situation.
Yeah, thank you very much.
You're welcome.
Okay, Laura. I mean, we all dream of a harmonized data collection, I think, when people go for testing across countries. Do you think this dream will become true? And what do you have some successes to tell us?
Yeah, I hope also to have all this data. For the moment, we are waiting to close 2024 collection of data in order to have the analysis of what we have. For the moment, not much harm reduction services have joined the network, so we expect that in the future that is going to happen. But we have already harm reduction services in the network, as for example, Odysseus is part of the Quotas network. And I think that it's really important to, instead of have this extra module for harm reduction services, to have all these main questions included in the main data collection form. So in this way, we are going to have this information from all the services that are members of the network. So we are going to have important data on drug use and just as an example, the fact of including hepatitis B testing in the data collection form means, for example, that the organizations in Catalonia start asking to the health government, we need hepatitis B rapid testing, so please give us a test. And they have started already to perform hepatitis B testing, rapid testing in the services, so it's a success. Okay.
Thank you. Mireia, from your perspective, what do you think is the major advantage of digital health services, and who do you think would profit the most, clients or services, or both?
I think that to answer the last question, we will need to wait a little bit more, maybe until the BOOST project finishes and is everything implemented. But the main idea also with this project is to also help people to be aware about how important it is to be inside these digital tools, how they can facilitate your life. On Sunday we were doing a workshop about how important it is to integrate all our data and to see also trends from other countries, also to compare between years when we will have data from several years, and also to try to monitor also at your own level. You can monitor in a lot of different ways, and the idea also with a new tool that we are developing for correlation for this questionnaire, and also a type of dashboard that all the organizations can have access and can play with their data. We hope that then you are not so scared with this data, and you can see the power, because also this can help you at national level, because data can visualize a lot your services, but also can visualize what is not working in your country. So try to help organizations to be more powerful with their own data. And then I think that also this will have a lot of benefits for the clients when the organizations can feel more empowered with their own data and can have it more accessible.
Thank you. Thank you very much. Iga, you already pointed out the barriers, but also the adaptations. So do you have any final words, any success stories about the data collection?
Yeah, I think it's difficult to tell. I mean, hopefully the second round will be a success story, but this is yet to happen. So, I mean, yes, I don't want to take your merit, but I think the biggest success story is really the response rate that you put with their survey. Yeah, I think that the kind of advantage, whatever use of the survey, except for kind of providing a picture of the general landscape of infectious disease service provision in low-threshold community-based organizations, is simply, but we also did needs assessment questions, as I said before, to inform the other work packages, and I think that I hope that it was helpful for the other partners in the project to develop really their activities and to focus them on really these areas which were identified as exhibiting any kind of gaps or blind spots in the service provision. I think that's it. That's all I can say at the moment, I guess.
Thank you. Okay, we come to Lynn. Lynn, do you have any recommendation for a harm reduction service who wants to start working with peers and people with lived experience in the field of testing, linkage to care of viral hepatitis and HIV? Any message, strong message? How to start?
I suppose providing space for people to gather, for providing space for peers, for people who use drugs to be in a space where they feel safe and they can, talk about the issues that they're facing in terms of barriers, but also to recognize the expertise that people have with living experience and to pay people for their expertise. For services to be brave. A lot of services, are reluctant to pay people, but just to be brave, to provide physical space, recognize experience. I think to value community-led monitoring as well, because we know that it works. There's evidence that it works. So, yeah. Just pay people for their expertise.
Yeah, I think so. This is very important. Thank you very much. And Georg, maybe last words on how will you bring all these great content and all the different aspects together in the Boost project? Maybe,
Do you have half an hour?
Encouraging words.
Now, before I start, I also wanted to give credit to Eberhard, because he was at the cradle of this project, in the project development. And it is very complex with a lot of different steps. So he prepared something which we are now implementing. But I think what we are proud of is that so many people do contribute from different regions in Europe, from different perspectives, from different expertises. So whether it's the lighthouses, whether it's Euro input, I think that is something which is the strong side of the project. And in that sense, because we have all these partners, I'm trustful that we do integrate all these different elements. And for those who are interested, we have some flyers here. Please feel free to take them.
So thanks to all of you. Thank you very much. That was really very interesting. I hope the audience also had profit